So welcome everyone to this first Pain Journal Club, and this is a new thing which we are starting, and I think I'm sure you will give your constructive feedback as you have been giving till now. So this is a short introduction about Mumbai Pain School. We already are aware of the disparities of pain standard across the country as well as the world, and it's also time and money consuming. So Leicester Pain Education has partnered with Panisha to start Mumbai Pain School, and the goal is to provide online on-demand learning, and the basic courses are free initially, and we are also having the hands-on cadaveric workshop as and when the COVID situation permits. It's said that the best teachers, they teach from the heart and not from the book. So I'll just give you, this is the first session, so I'll just give you a brief introduction of what is a journal club. Most of us will know, but for the benefit of rest of us. So the word is journal club. So club by itself, you know what a club means. So it's a gathering of people, and they join together to do activities which are often fun activities. Okay. So our journal club is also an activity, and it can be fun, and we are joined by a common goal. And important thing here is that instead of doing activities which are just spending time, we have a very different approach here, and this approach is that we are going to critically evaluate recent academic literature, and then draw some conclusions out of it, and probably use it in to the benefit of our own practices, as well as for the benefit of the society in general. Okay. So the important point to concentrate here is that too many cooks spoil the broth, too many ideas cannot communicate anything. And as a result, every journal club is focused on a single thought or idea or a theme. And this is what is conveyed by this slide. So there is a defined subject in each and every journal club. So we have a lot of people attending here, and each one of us is an individual with our own thoughts, actions, ideas, thinkings. However, the important point to note here is that the participation is very important. So the attendee participation is one of the most common characteristics of a journal club. So it all started, the earliest journal club, the history, when I tried to find out. So I could find that in the mid 19th century, that is 1840s or 50s. So Sir James Paget started this the first journal club in Bartholomew's Hospital, and few years afterwards, Sir William Osler in 1875, around 25-30 years afterwards, he started the journal club at McGill University in Montreal, and this is what it looked like at that time. This is a 1900 picture, which I have tried to just showcase. And if you see, the cost was a factor for Canadians, but you know, the idea of combining together, sitting in the evening, having some beer together, and or maybe some savories, and then reading journals was the idea for the British. So different reasons, but the purpose or the thoughts were almost the same. So Tinsley Harrison, the founder of Harrison's Principle of Internal Medicine, he started a journal club wherein he invited the colleagues to come to his house twice a month, but his purpose was entirely different, and his purpose was critical evaluation. So you saw that there can be different purposes of the same thing, which is a journal club. And the common denominator is time and discipline. Okay. So these are the common denominators of holding a successful journal club and probably deriving enough benefit from it as well. So this is very important tool, but it has to be used carefully. And equally important is healthy skepticism. So the skepticism should be there. So you need to criticize the paper for the faulty techniques or for something which you find could have been different. However, it should be done in a healthy way and a positive way. Or if you like something, you can also praise the paper or the authors or their techniques, and this can give good results in a journal club, which can be benefit for everyone. So this was a short introduction. Now I will like to introduce to you today's speaker. And today we have with us Dr. Sanjog Mekewar. I will now request Dr. Sanjog to start sharing his screen, and he can begin with the presentation for today. We have two papers for today, and for those of you who do not have the access to those papers, I will just post the links here in the chat box, and so that you guys can just have a look, and probably this can help you guys to understand the paper better. Okay, so just allow me a moment and I will just post the links. Okay, and meanwhile, Dr. Sanjog, welcome. And I think some of us know him. He has been our fellow in pain medicine for the last year. And I think you can begin now. Thank you.
Okay, good evening, everyone. Today, the first article that we are going to discuss is an article which was published. Can you hear me?
Yeah, just a second.
Yeah.
Dr. Sanjog, we have our faculty for the evening. I could not see him earlier. So we have Dr. Sadiq Bhayani also with us. I will, I mean, he doesn't require any introduction, but I'd like to formally welcome him. And he will be there with us. So he's a consultant in the NHS UK and the co-founder of Mumbai Pain School, Gulf Pain School, and zillions of achievements now in pain in his name already. So please begin now. Thank you.
Okay. So the first article that we are going to discuss today is an article which was published last year in BMC Musculoskeletal Disorders, and it was titled as "Cooled Radiofrequency Ablation of the Genicular Nerves for Chronic Pain Due to Osteoarthritis of the Knee: A Cost Effectiveness Analysis Based on a Trial Data." And the authors of this article included Mehul Desai, Anthony Bentley, Dr. William Keck, Thomas Hagg, Rod Taylor, and Helen Deakin. So this is this journal has an impact factor of 2.27, and this particular study was funded by Avanos Medical, who provided the consultancy payments to all the authors for the study. And William Keck was actually an employee of Avanos who provided input on the clinical trial data. That he designed the economic model and was a contributor in writing the manuscript. Okay, so the question that this article asked was, is cooled radiofrequency ablation a highly cost-effective treatment option for patients with osteoarthritis related knee pain compared with $100,000 per quali threshold typically used in the US? So that is a threshold which is used to define how cost effective is the treatment modality that we are using. So a short introduction. Now, osteoarthritis knee is a non-inflammatory degenerative disease which is associated with major economic burden and social impact of absenteeism. And arthroplasty is an effective and established terminal therapeutic option for a late stage osteoarthritis related pain and dysfunction. But arthroplasty is only indicated for stage 3 or stage 4 OA according to the Callan-Green classification. And in the initial states, we generally go for the intra-articular steroid injections, which are often considered as the first line invasive treatment. but they can only provide a short-term pain relief. Now, radiofrequency ablation of genicular nerves nerves is an entity which has come into being in the recent years, and it is the only FDA-approved radiofrequency treatment to be approved by the FDA for management of OA knee pain. Now, cost effectiveness analysis is a standard approach which is used for estimating the resources used and the health benefits that we can achieve through the use of that intervention. Now, this paper is actually based on a trial which was conducted in United States in 2019 and published in the paper Regional Anesthesia and Pain Medicine in 2019 with a title of 12-month analgesia and rescue by cooled radiofrequency ablation treatment of osteoarthritis knee pain, results from a prospective multi-center randomized crossover trial. So this was a trial which was conducted over a period of 12 months, and this basically included a comparison of cooled radiofrequency ablation and intra-articular steroid injections in the patients. Now, the inclusion criteria for this study and the study, the trial which was on which this study was based, was the patients with grade 2 to grade 4 osteoarthritis knee patients within 12 months prior to diagnosed within 12 months prior to the study, and knee pain for 6 months or more that was unresponsive to the conservative treatments. Now, the other inclusion criteria included the numerical rating scale pain score of 6 or greater for the index knee, that is the knee that we are investigating. Then the Oxford knee scores of 35 or less, positive diagnostic genicular nerve blocks, which are defined as a decrease of more than 50% in the NRS post diagnostic block if there is no change in the standard medications that the patient is taking. So I will just go through this, the methodology. This is the methodology for the trial that was conducted. So that will help us know how was the study conducted. So for the trial, there were 223 patients who gave consent for the study, of which 82 of the patients failed the trial. Trial means, okay. So 82 of the patients failed the trial. Trial means the diagnostic genicular nerve blocks were given to these patients, and there was no pain relief in these 82 of the patients. So they were excluded. Now, the remaining 159 of these patients were randomized into 76 patients who received a cooled radiofrequency ablation of the nerves, and 75 who received intra-articular steroid injections. Now, over a period of time, they were assessed at 1 month, 3 months, 6 months, and then at 12 months. Now, this is how there was some of the patients who were lost to follow-up, who were excluded later on, some of them who withdrew from the study, and after 6 months, ultimately 58 out of the 76 patients in the CRFA group, they completed the arm, and in intra-articular steroid group, again 68 of the 75 patients completed the arm. But after 6 months, in this study, there was an option given to these 68 patients who had intra-articular steroid injections. They can opt for the cooled radiofrequency ablation methods. So we can see at 12 months, only 4 of these patients after 68 actually completed the arm of the intra-articular steroid injections. And some of them were lost to follow-up, some withdrew, and some of them crossed over to the CRFA methods. So, and in CRFA group, out of 58, 52 actually completed the group. So this was how the study was basically conducted. Now, in this study that we are analyzing today, the cost and effectiveness analysis were developed in the Microsoft Excel to evaluate the costs and the health outcomes of patients undergoing radiofrequency ablation or intra-articular steroids. Now, comparative efficacy data. Now, efficacy in this study was determined by measuring the mean Oxford knee scores. How much improvement was there in the functional status of the patients by measuring through the Oxford knee scores. And they were used to determine the health gains which was achieved by the patients undergoing each therapy in terms of quality adjusted life years. So this quality adjusted life years it was calculated and by converting the OKS data from the trial into the utility scores by using EQ5D. So they use some formulas, and this OKS data is converted into the utility scores. And the range of these utility scores is 1 to 0. So 0 is death and 1 is perfect health. So these values were calculated, which were later on, they were used as the quality adjusted life years. Now, there were two things, primary economic analysis and secondary economic analysis. In the primary economic analysis, the cool radiofrequency ablation was compared with the intra-articular steroid injections using a time horizons of 6 and 12 months post-treatment. Now, it assumed that the patients received only one intervention with either radiofrequency or intra-articular steroid at the study baseline. And the benefits and the costs included in the analysis reflect those associated with this baseline intervention. So these patients received either the radiofrequency ablation or the intra-articular steroids, and no other intervention was done during the 12-month period. Also included in the cost of in the cost analysis of these patients was the genicular nerve diagnostic blocks for the radiofrequency ablation groups. So in the trial, actually all the patients, as we have seen in the diagram, that all the patients received the diagnostic genicular nerve blocks. But for cost analysis, this diagnostic block was included only in the radiofrequency ablation group, because normally we don't give for diagnostic blocks before intra-articular steroids, and no repeat treatments were included. In the secondary economic analysis, the CRFA group was compared with a crossover group. So after 6 months, some of the patients on intra-articular steroids, they actually crossed over to the CRFA group. Secondary economic analysis was the comparison between the original CRFA group and the patients who crossed over to the CRFA group. And the assessment was done at 7th, 9th, and 12 months post-study baseline, from the baseline, which corresponds to 1, 3, and 6 months post-CRFA treatment. So in this patients, all patients in the crossover group received intra-articular steroid at the baseline, followed by radiofrequency ablation at 6 months. So costs include the cost required for the intra-articular steroid at the baseline, plus the genicular nerve diagnostic block of these patients, which was done before giving the radiofrequency ablation, and the cost of the radiofrequency ablation. Now, the costs which were incurred were estimated from the US Medicare perspective and were derived from Centers for Medicare and Medicaid Services fee schedules, and included standard physician in-office or in-hospital and hospital payments for intra-articular steroid and radiofrequency ablation and genicular nerve block procedures. And the reference year for costs was 2017. Now, primary analysis reflected the settings of care and procedures administered in the clinical trial, while secondary cost analysis included the real world cost scenarios. So they used two real world cost scenarios because in clinical practice, actually, some of the procedures like the genicular nerve blocks can be done at the office setting, or it can be done at the OPD basis. So depending on these clinical scenarios, they divided this into two scenarios and conducted to account for any differences likely to be account in the clinical practice. And they finally found out what are the costs incurred. They also calculated the incremental cost effectiveness ratio values, where the radiofrequency ablation resulted in health benefits at an increased total cost. Then one-way sensitivity analysis were conducted to assess the sensitivity of the model results to changes in efficacy and cost inputs. So these are the results of the studies. In the primary analysis, where the radiofrequency ablation versus intra-articular steroid were compared at 6 and 12 months time horizon. So we can see the incremental quality adjusted life years gain of 0.091 at 6 months in the CRFA group compared to the IAS group. And the incremental at an incremental cost of $1,711, and cost per quali gained was $18,773, which was very well below the $100,000 threshold that the US Medicare system has. And at 12 months, this cost per query gained was again reduced from 18,000 to 7,462 because of the increase in the query gained at the 12 months period. Now the secondary analysis, which was done for the real world cost scenarios, here also we can see that the cost per query gained, they were well below the $100,000 threshold. At the 6-month horizon for real world cost scenario 1, it was $21,000, and at 12 months it was $8,296. And for the scenario 2, 6-month time horizon, the cost per query gained was 17,564, and at 12-month time horizon it was 6,768. Now this is a tornado diagram to help us to calculate the one-way to do the one-way sensitivity analysis, and this is used to assess the sensitivity of the model, which results to changes in the efficacy and the cost input. So if there are any changes in the if we change the OK scores of, or we change the inputs, then what is the change in the incremental cost effectiveness ratios? So this diagram shows us these changes. And this is a graph which is the probabilistic sensitivity analysis. And what is done here is all the parameters are varied independently, and they help us assess the uncertainty around the conclusions. So this is basically a scatter plot, and this gives us the how much what is the probability of being a cost-effective intervention. So we can see as the cost increases, if the costs are less, then the probability of being cost effectiveness is high, and as the cost increases, then it forms a plateau. So this study is the first to assess the cost effectiveness of radiofrequency ablation. And using the radiofrequency ablation resulted in significant improvement in the OKS versus the intra-articular steroids, which translated into incremental cost effectiveness ratios below $19,000 per query at 6 months and $8,000 per query at 12 months. Now the estimates reflect the sustained benefit of radiofrequency ablations observed over 12 months. Now, the sensitivity analysis demonstrated the economic evaluation to be robust to variation in data inputs, and that there was a more than 85% chance that the CRFA is a cost-effective method with intra-articular steroids at the $100,000 query threshold. Now, comparison of the early versus the delayed CRFA, that is secondary analysis that we did. So, immediately CRFA treatment, so it evaluated that the immediate CRFA treatment, if given to the patient, it may be cost saving and offers greater query gains compared with the delaying the CRFA treatment in the patient. Now, there are some internal limitations which the authors have accepted. And these are, first is that the 12-month CRFA IS analysis is limited by the large number of subjects who were dissatisfied with the intra-articular steroid after 6 months, and who crossed over to receive radiofrequency ablation, which resulted in only 3 subjects or 4 subjects who remained in the actual intra-articular steroid arm and having OKS data available at 12 months of follow-up. Second was that the cost effectiveness beyond 12 months is not known. So the study was done only for 12 months. So what is the duration of pain relief, and what are the, if the patient is requiring any other intervention post 12 months, we don't know. Second is, third is the trial and the economic analysis did not allow for repeat treatment. So patient did not receive any repeat treatment for a 12-month period, or switching to alternate treatments in the case of waning treatment effect. Other internal limitation was the costs other than the screening and treatment were excluded, like the nurse follow-up and physiotherapy. So some of the patients may be requiring these services at homes, which incur additional costs, but they were not included in the study. Now, the improved effectiveness and durability of radiofrequency ablation against the intra-articular steroid would make it likely that these costs would be higher for the intra-articular steroid treated patients. These cost exclusions would likely mean that the current analysis is a bit conservative. Now, there are some strengths of this study. So the cost per query gained not only assess the costs involved, but the clinical benefits of the interventions. There is it is a very cost-effective analysis. The trial was already done. It was only the data was collected, and there was no additional costs required for the analysis. there was good matching in the trial, and the acceptance of the inherent limitations by author. So it is a good sign. There were some pitfalls, the study was funded by Avanos, who provided the consultancy fees to the authors. And furthermore, one of the authors was a direct employee of the Avanos Medical. So studies which funded studies, definitely some of them have the chances of bias, which can be a reporting bias or a selection bias, and which we have to consider in this literature. Now, in the trial, all the patients were given diagnostic genicular nerve blocks for screening of patients. This may have implications in the Oxford knee scores of the IS group. Thank you.
Okay, thank you, Dr. Sanjog. I think we can have a discussion on this now, and then we can move on to the second paper, which is also very interesting. And so let me invite Dr. Sadiq for the discussion. So Dr. Sadiq, can you hear me? I think he's not in the meeting. Okay, sure. So I'll take the discussion forward till he gets back online. The most important point here is that it's a pharma-driven or an industry-driven study, and it has to be taken, with a pinch of salt. However, it is not uncommon, especially in the United States, for the industry to do FDA-supervised trials, and hence supporting has to come from somewhere, because otherwise the techniques and technologies won't be developed. So, my take on this is, of course, that this can be beneficial if it is used in the interest of the patient, and if the data which is used is authentic. Because if the data can be authentic, then no matter who funds it, it's in fact better if the company is funding it. Nobody is, it's the government or the patient doesn't pay. So this is important here to consider these small issues, and this is my opinion on it. Also, somebody has asked in the chat box, is intra-articular steroid injection still recommended? So maybe this can be one of the shortcomings. They could have done with probably some other things, that is maybe a PRP or something, and this could have been this could have given another insight into this thing. Also, was the study blinded? Were the patients knowing what they are getting? Because it's very different. If I get an intra-articular steroid injection, it's just one injection and we are done.
No, it was not blinded. It was open to the patients to decide which type of treatment that they will take.
Yes.
And it cannot be blinded from the doctor's point of view also, because you have to do the intervention.
The three needles have to be inserted, and
yes,
as opposed to the one. So this is another factor, since so they get a 30% benefit of the placebo response as well, because they are going for some big treatment, and they are going for some better treatment. They may feel, and especially the patients in the US, they will like to have the better and the best treatments at their end. Okay, so anybody wants to add anything, they can just put in comment. If you want to speak, you can raise your hand, and we can allow you to speak as well. So just raise your hand, and we can unmute you and allow to speak if you want to speak. So let me read out some comments here. So is the diagnostic block done by the same doctor who performs the cooled RF? And so does is this mentioned? I don't think I read it anywhere.
This is a multi-center study, so it was conducted all over many centers over the United States. So
but the patient will obviously go to the same center only.
Yes,
so
yes, it was yes.
So,
yes.
But at the same center, there may be multiple pain physicians. So I don't think the study says that they were performed by the same pain physician. It is silent on this matter. So it is another thing which could have been mentioned. However, since the technique is a little different, so I don't think it will make much of a difference, because in diagnostic, you just take the ultrasound, just see the artery or probably go near to it and just give the drug. And, you have a significant margin of error as well. So I think this can, this is a good discussion point, but ultimately it won't make any difference. Okay. So the next comment is, what about the post TKR pain? Were any patients included? So I don't think these were virgin knees, right? They were not post TKR patients.
They were grade 2 to grade 4 ONs.
Yes. So grade 2 to grade 4 ONEs were taken. And one more point which I would like to ask Dr. Sanjog, was there any distinction made between grade 2 and grade 3 and grade 4? I mean, how many people were grade 2? How many people were grade 3? Does the study
There was no mention of anything like this.
So this also is one of the important points, because usually we will like to go for the neurotomies at grade 4 or maybe grade 2 or something, and with higher chances of success. In the earlier the grade, probably I will assume that the better the chances will be, and also the other effects can be there. So the another confounding factor which can be there is, have they mentioned about any exercise therapy or a rehab plan post the procedure?
No, the inclusion criteria mentions that the conservative treatment has been failed in these patients. So everything has been tried. After this,
I can understand, but once they break the pain cycle, because this is not the ultimate, the ultimate aim is to break the pain cycle. Any which ways the nerves are probably going to regenerate, or patient is going to develop the alternate mechanisms, or if the alignment is not proper, anyway you cannot sustain it for long. So do you think that they should have, I think, mentioned about the post procedure rehab?
Yes.
And how long did they follow up post procedure to to declare the patient as pain free?
It was a 12-month follow up. So the trial was conducted over a 12-month period.
No, I'm just saying that from the recruitment of the last patient and doing his procedure till the point the study followed them up. So how long did they follow their last patient? I don't think they mentioned that, right?
They did not mention.
Yes. So this is another point that the longevity of the treatment is not mentioned. And any word on the reason for the crossover? They mentioned that the patients were crossing over from the intra-articular steroid to the other group, the pooled RF group. So is there anything which you can
I guess since the study is in US, so all the patients must have been given all the options. They must have explained everything about both the advantages and disadvantages. And whatever patients, if the patients were not, no.
Let's not assume things. They have not mentioned it. They should have mentioned. This is another point which would have been, a confounding factor, because what were the pain scores before they consider? This was subjective and not objective. Okay.
Yes.
So there's no criteria mentioned. I think in the study which
they have just mentioned that who were unsatisfied with IS, they crossed over to
that is okay. That is understandable. Of course, they'll be unsatisfied. But number one, they are getting treatment for free. Number two, we don't know what are their work issues, what are whether they are getting some compensation, whether they are getting salary, or we don't know anything. And who are these patients? This is not described. So at least the criteria should have been more. You can say they should have
objective.
So this probably these few could have been the points. However, this study nonetheless is a robust design, other than these small issues. And somebody is typing option PRP plus pooled RF. Of course, the company, they just wants to introduce the technique. So once it is through in the insurance, especially in the United States, probably they can do all this PRP plus pooled RF and other things, and this can be very important. And authors have declared the interests, and obviously they had to, but they have declared the results. And the good thing about this is that after this study, many studies have come which have been able to reproduce the results. So this is also a positive point now, because it's already about a year or something. And we have some, if you do a search, I could find a lot of studies which could give some options. Okay. Somebody is asking, could I get the recording of this presentation? Okay. So we'll post it on Facebook page and you can access from there. Okay. So let's move on to the second presentation now. The second talk is equally interesting. In fact, I found it very interesting when we discussed, and I think it will be a great, uh, academic feast if we can just see. This is a new technique, and I was very excited to read about this and new technique of the genicular targeting. Okay, so you can start now. Thank you.
So the second article was published in 2020 in Regional Anesthesia and Pain Medicine with the title of Current versus Revised Anatomical Targets for Genicular Nerve Blockade and Radiofrequency Ablation, Evidence from a Cadaveric Model. And the authors were Loic Fonque, Catherine Weidman-Behetz, Arnaud Stiert, Jean-Eric Kauman-Kausi, Christine Bernard, and Oliver Cornum. So this study was conducted in multiple centers in Brussels, and it was published in 2020. The research question was, are the revised anatomical targets for genicular nerve blocks or radiofrequency ablation more accurate compared to the current targets? So the technique of radiofrequency ablation of genicular nerves was first described by Koi et al. In 2011. They basically did cadaveric dissections and identified the spots, the points of needle placements. And they mainly described the locations of three nerves related to the knee joint. And because of the limited size of the RF legends, its success relies on the precise placement of the cannulas. So it is very important to determine the point of cannula placement, because that if it is away from the nerves, then the purpose of the lesioning is lost. So idea is to place the cannula as close as possible to the nerves supplying the knee joint capsule. Now, in the introduction of this article, they have mentioned that there are many studies are coming up recently which are proposing the new anatomical targets, and thus this study, which is also a cadaveric study, is very much required at this point, and this is the rationale for conducting this study. Now, in the methodology, this study was conducted in two steps. First, they did a pilot study. This was done to design the best method to assess the accuracy of the anatomical landmarks. So whatever problems they were having in conducting this study, they identified them and they found a solution to it, so that there were no problems in the main study. So in the starting, they brought about, they first started with directly doing the radiofrequency ablation, and then doing the dissection in the cadaver. And after in these cadavers, they could not find out the exact location of the tip of the cannula, because even after 3 times of the magnification, they could not find where was the ablation done. So they replaced this direct radiofrequency ablation to injection of a dye. But even after injection of as little as 1 ml or 2 ml of dye, the dye was spreading large area. So again, it can act as a confounding factor, because if it is spreading and it is coming close to the nerve, then it will give us a wrong idea of the needle placement. This staining the stellate of the cannula and then inserting it into the needle, which would which will form a black mark over the tip of the cannula. So this was done 2 or 3 times before remove the cannula and then the dissection. So after the dissection, they could find the black dot, and then they measured the distances from the nerves. We'll see in the methodology what they did. So in the main study, 14 knees from 7 fresh frozen cadavers, 4 men and 3 women, aged 78.4 plus or minus 10 years, without evidence of prior knee surgery or trauma, were used For each cadaver, one knee was randomly assigned to the radiofrequency simulation procedure with current targets, while the other one underwent the same procedure with a revised targets. Okay, so as we know, the current targets that we use for the superomedial, superolateral, or inferomedial genicular nerves is for the superomedial, we use the junction of the femoral condyle and the shaft. And in the lateral view, we generally go till the half of the diaphysis of the femur. And similarly for superolateral, we go at the junction, and laterally we go till the middle of the diaphysis. Similarly, in inferomedial, we go till the middle of the diaphysis. These were the current targets. In revised anatomical targets for fluoroscopic guided RF ablation of genicular nerves, what they proposed was for superomedial genicular nerve, at the junction of in the AP view, you have to go at the junction of the shaft of the femur and the condyle, and in the lateral view you have to approach till the adductor tubercle. So you don't have to be at the middle, but you have to approach, insert the needle tip up till the adductor tubercle, just above the adductor tubercle or just distal to the adductor tubercle. So this is about the superomedial. In superolateral genicular nerve, in the AP view, you have to go at okay. So in the AP view, you have to go at the junction of the shaft and the condyle, and in the lateral view, you have to go till the junction of the condyle and the posterior cortex of the femur. So again, you have to go till here, not till here. The needle placement of the inferomedial genicular nerve they have proposed is the same as the current anatomical targets. Now, these were the three nerves that are targeted in the current scenario. But in revised anatomical targets, they have introduced two more blocks. One is for the infrapatellar branch of the saphenous nerve. So for localization of this nerve, they have drawn a transverse line from the apex of the patella, and one more line transversely from the top of the tibial tubercle. And then 4 centimeters from the apex of the patella, a longitudinal line is drawn which joins these two transverse lines. So this needle can be placed anywhere on this line. Now, for the one more nerve is there, that is the fibular nerve, recurrent fibular nerve. Now, for this nerve, you have to approach the Gerdy's tubercle. You have to see the Gerdy's tubercle, which is the most prominent part on the lateral condyle of the tibia, and you have to just go 1 centimeter below this. And this is where the recurrent fibular nerve will be there. So these both are subcutaneous nerves, and there is no need of the fluoroscopy in these cases. So these are the revised anatomical targets that is proposed. Now in methodology, what they did is they did to assess the accuracy of each cannula placement. They traced the hypothetical target largest RF lesion volume. So they considered a RF lesion volume which has a transverse diameter of 7.4 mm, longitudinal distance of 12.9 mm, and a distance beyond the tip of 2.4 mm. So this was a hypothetical RF lesion size around the nerve that they have considered. Now finally, at the end of the dissection of each knee, they placed the needles, and then they measured the distances from the tip of the cannulas till the nerves, and then they found the accuracy by assessing if this needle tip was lying in the area, this hypothetical largest RF lesion volume, if it is residing in this area. So this will tell us about the accuracy of the needle placement. Now, after this analysis, they did the dissection of each knee, and they actually saw the full course of the superomedial, superolateral genicular nerves, and they fixed, you can say, a marker through the trunk of these nerves into the underlying bone before their distribution to the knee capsule, and then they performed the AP and lateral radiographs. Now, these locations for the 14 specimens were consolidated, and to generate a frequency map of the most accurate targets for the fluoroscopic guided genicular nerve RFA in a sample. So this we will see a bit later. Now whatever their findings, the various distances that they got, they were described as median, and the accuracy of the cannular placement for each nerve with both techniques was described as proportions and compared using the Fisher's exact test. We used the Whitney U test to compare the distance from the nerve to the black mark in both techniques. Now, these were the results of the studies. Now, the median distance and range from genicular nerve to the active tip of the RF cannula, comparison of the classic targets versus the revised targets. So, in superomedial genicular nerves, the P value was significant. So, you can see with the classical targets, what you got was a range of 14 to 20 mm distance from the nerves, and a median distance of 19 mm. But with the revised anatomical targets, you were bang on the nerves. So it was very significant the results were significant for the superomedian genicular nerves. Now, superolateral genicular nerves, if you consider classical method, now the median distance was 1 mm from the nerve, and for revised, it was again 2 mm from the nerve. So it was not significant. Now, for superolateral this was for the transverse branch. Now, superolateral genicular nerve has after it reaches the point of the junction of the shaft and the condyle, it divides into lateral and a descending branch. So the results were not significant for the lateral branch. Now, for the descending branch, we can again see the results were quite significant in the revised anatomical landmark group. Okay. And for the inferomedial genicular nerves, both the classical and the revised methods, they proved very good. They had very good results. Now, if we see the comparison of the accuracy rate of the lesions with classical versus revised targets, again, it was significant for the superomedial genicular nerves. So revised targets, they were they were able to identify the nerves 100%. In superolateral genicular nerves, there was 64% accuracy with the revised targets against 36%. So there was improvement, but it was not that significant. For inferomedial genicular nerve, it was 100% accuracy for both the methods. And since the infrapatellar branch of the saphenous nerve and the fibular nerve, they were not treated in the classical targets. They were only treated in the revised targets, and they also had 100% accuracy rates. Now, in discussion, they have told that Koi et al., who first described the procedure, dissected only 2 specimens. They chose to target only 3 nerves, that superomedial, superolateral, and the inferomedial, and they acknowledged that the denervation of other articular branches would probably give different results. So these the results published by Koi et al. Were very primary data, and but following those studies, there were many studies which have questioned the actual placement of the nerves. This is actually the scattered diagram that I was telling about in the methodology method. Now, this is for the superomedial genicular nerve. So all the knees in which the needles were placed accurately, that the accuracy rate was good. Now, marked on this diagram. And you can see that normally what we place, the needle tip at this level in our current methods. But the target, when we reach the target above the adductor tubercle or just in front of the adductor tubercle, now the results are good when the needle tips are placed at these levels for superomedian genicular nerve. For superolateral genicular nerve, now what they have said is, since there are 2 branches, the transverse branch and the descending branch. So if we just do the radiofrequency ablation at this level, there are chances that this transverse nerve or the longitudinal nerve will be spared, and the pain will persist. So what they have suggested is to do ablations more than one at least at these 3 locations. So these are again at the junction just above the at the level of the posterior cortex, one lesion at the junction, one above and one below. So this will take care of both the branches, and the results will be good. Okay, so the inherent limitations included that the accuracy of the cannula placement would have been more definitely assessed if the RF lesions were directly appreciated during the dissection. So what they did is, instead of looking for the RF lesions, they actually saw these markings that that they recognized after the dissection. So if radiofrequency ablation would have been used, then it was a direct representation of the actual intervention that we do. Secondly, the larger sample size would have allowed to create a more exhaustive figure map representing the entire spectrum of variations of the target points. Strengths are that the pilot study is done before starting the main study to address the difficulties. So whatever difficulties they could encounter, they corrected in the pilot study, and so that the main study was done very smoothly. Then during dissection, post cannula tip marking, the whole course of the articular branches were dissected and studied. So they actually studied the whole course of the superomedian, superolateral genicular nerves, and from where they could find out that there are in fact a lot of variations in the superolateral genicular nerve compared to the superomedian genicular nerve. Pitfalls of the study is that the study has been done in cadavers with assessment of only the needle placement relative to the nerve. Mirroring of the study in sample population with assessment of pain relief and functional improvement is warranted. Thank you.
Thank you, Dr. Sanjog, for the presentation. So I think we have Dr. Sadiq with us. So I think he can now join the discussion. Dr. Sadiq, can you hear me? Yeah, I can see you.
Yes, Sidharth.
Yeah, so I know that you are in between cases, and thank you so much for helping and joining in.
No problem.
Yeah, so I mean, now let's participate in the discussion. Over to, and just Sanjog has pointed out the pitfalls or the advantages or why it is so different, and I think there's nobody better than you to tell, because you know this is your specialization, and I think joint innovation is your key area of it.
Sure. So do we have any questions? Anybody wants to ask any question at all?
We don't have anything in the chat box, but I will let you know as soon as they pop up.
Fine. So I think from my point of view, you know, the papers have evolved, or the research in this field has evolved over a period of time. So if you look at the Choi paper described use of 22 gauge needle, okay? And people were still getting, like patients were still getting the benefit, but there was a high chances of failure rate because, you know, we were using small needles, the lesion size was smaller. Then came on a paper from our dear friend Leo Caporal. Leo described it, bigger is better, okay? So then we went on from using 22 gauge needle to sort of 18 gauge needles or 16 gauge needles. And then came on the cold radiofrequency treatment, and the success rate went up. But then at the same time, there was a huge kind of, you know, a deficiency of our knowledge with regards to the anatomy. And, you know, the last paper the paper that's just been presented, the new anatomical targets. Now we know if you want to target these nerves, you need to go way posterior rather than in the middle of the shaft and the condyle junction. So I've changed my practice. Nowadays, I target these nerves, and I think the important clinical pearl. So I'll give you a few steps. So first thing to do is to actually find out the location of the knee pain. If the patient says, I've got a pain in the front of the knee or the anterior compartment, then you can do this procedure with some success. If patient says, my pain is in the posterior part of the knee, this procedure is bound to fail because the anterior nerve supply is not targeted. I mean, you know, you can't, you know, people have tried IPAC blocks, people have tried, you know, pulsed RF in the IPAC plane. None of them have worked in my practice. So I always tell the patient, if your pain is in the mostly posterior compartment of the knee, unfortunately, I won't be able to help you with the interventions. Medication is an option. Now, if they say they have a pain in the medial compartment, you would do superomedial and inferomedial genicular nerve blocks. You don't have to target the lateral compartment. If they have a pain in the lateral compartment, then you would do superolateral genicular nerve, and then decide whether you want to do a radiofrequency treatment. You could divide the knee pain patients into two groups. One is the virgin knee, so patients who've never had any knee surgery. And the second group is patients who've had previous surgery, and they are into the chronic post-surgical pain group. Okay. The chances of success are very high if you're doing this procedure on someone with the virgin knee. Okay. You will find patients who've had previous knee surgery, this procedure isn't that successful because there's a huge element of central sensitization. So these patients will have a pain memory or neurotag, and I tell them that you will find that this procedure will only help in about 30% cases. So, you know, and that's the realistic expectation you have to set with them. Okay, no matter whether you use conventional RF, cooled RF, the chances of success rate are still about 30% in chronic post-surgical pain patients, but they are up to 50 to 60% in patients who've never had knee surgery. Okay, so those are the two groups. Now, then comes on to how to assess these patients. So you know, majority of the papers you probably look through will recommend you need to do a diagnostic block. Without that, you shouldn't be going ahead with the RF, because what diagnostic block will confirm, is there an element of peripheral sensitization or a central sensitization? Because that's what will decide the success of your treatment. If the diagnostic block is proved to be beneficial, then you can do RF. And then doing RF with the right anatomical landmarks, as been discussed now, is what will decide your success rate, and the size of the lesion and the size of the needle. Now, thing to keep in mind when you do diagnostic block, don't go around and start injecting 5 cc's of local around each nerve, because that's not a diagnostic block. I'm on the webinar. So,
all right, I need to show you.
Okay, sorry, that was Yahya just sitting next door. He's got a clinic. So, when you do a diagnostic block, I use all the I use 2 cc's of local, 2% of lignocaine. That's in my practice. I use the ultrasound. I don't do any X-ray guided diagnostic blocks. I get the patient in. I usually ask them to walk, jump, do whatever they do that brings on their pain. Okay, if it's an elderly person and they say, I get my pain when I stand up from the chair, I ask them to do that. I ask them, okay, how much is your pain? They say, okay, my pain is like 6 or 7 out of 10. Then I do the diagnostic block with 1% lidocaine. And 10 minutes later, I ask them to do the same maneuver and I ask them, how much is your pain now? And I give them the pain diary for 24 hours. So, you know, they have to mark the pain every hour for first 6 hours, and then they do 12-hour and 24-hour. So that's how I assess their pain. Hello? Sidharth, can you hear me?
Yes. Please continue.
Yeah, so if their pain score drops more than 60% or 70%, then I will consider them appropriate for radiofrequency treatment. Now, you will come across patients who will give good results, like the diagnostic block will last for good 2-3 months. So don't be alarmed by the fact, because what you've done is like very much similar to the medial branch blocks in lumbar spine. Okay, you get patients where you do lumbar spine diagnostic medial branch block and they get good 3 months of pain relief. And how do you explain that scenario? You've turned off the peripheral sensitization, they had a temporary pain relief, and the pain then eventually comes back. Now, those patients, what I do, I offer them another diagnostic block. I don't go ahead and do the radiofrequency, because that's where you will then pick up the false positives from your diagnostic block. Okay, so, you know, and the diagnostic blocks are easy to perform, you know, they're quicker in terms of time. Also, you know, especially when patients are paying privately, you know, you could actually save them the money, because if they're getting good 3-4 months of relief by just doing a 10-minute procedure, I'm not going to expose them to RF unless I know the diagnostic block is only lasting for 2 days. Okay, so that's my approach. Now, you will come across patients with chronic post-surgical pain and the scar pain. Now, those patients, I will not do an RF in the first place. Okay, there are 2 options now. One, you could do a hydrodissection of the genicular nerves, as Stan Lamb described in his presentation when we did a webinar. So you can use 5% dextrose, and you can do plenty of hydrodissection in the genicular nerve area and to release the pressure of these nerves, and you can get relief from that. Or the other option is if there's a severe allodynia, you could do local anesthetic and the steroid block. So you can reduce the neuritis, you can reduce the sensitivity, and then once they have had reduction in the allodynia, then you can do radiofrequency. You can do conventional RF, but you need to find out, do they have a predominant neuropathic pain or do they have predominant nociceptive pain? If they have predominant nociceptive pain, go ahead and do RF. If they have neuropathic pain, then you do local anesthetic and steroid or the hydrodissection with 5% dextrose or local. So that's how I would divide, and I would, in my practice, I use 16 gauge radiofrequency needles. I put plenty of local anesthetic beforehand so the patients can tolerate that. I don't do any sedations at all because I rely on the sensory stimulation for these nerves. Because, when I spoke to Leo, Leo does many of these, and they actually use, so he uses sensory stimulation as an endpoint. If your patient doesn't complain of any pain when you're actually doing the lesion, then you're going to bound to be failed because you're not in the territory of the genicular nerves. Because these nerves are very small, you need a very ultra high frequency probes to visualize them. The artery is a good marker, artery, and if you go next to the artery, you will get the nerve 9 out of 10 times, but you still need to do sensory testing. And then when you start the treatment, patient will say, oh, that's very painful in my knee. If they can tolerate that for 90 seconds, that's good. Otherwise, you do it for 30 seconds, you give a pause, you inject more local anesthetic, and you continue with the treatment. So that's how I would do the RF. And, so that's what my approach towards the management of the knee with the genicular nerve block and the RF. Okay.
Yeah, thank you so much for giving in such a lucid way. And I think you were not using the slides, but we still could understand most of the things. So thank you so much.
No problem.
I think I have some questions. Maybe you can help with that.
Sure.
This paper, they used around 17 or 18 cadavers. So
Sure.
I mean, this is a good number, but in their discussion, they mentioned that this is a low number. I mean, what is your take on that?
Put it this way, I think it's the cadaveric dissection. And I think, if you look at the studies from Toronto, I think David is one of my friends here in Wales. So David did his fellowship. David sent Burkett Laurent, I think. So he actually did a paper with Philip Peng and Ann Arger. And they actually dissected the cadavers and they mapped and 3D mapped the genicular nerves. So, even though there are 18 cadavers, there are good enough numbers with the 3D mapping, and you can actually make, there are 3 standard points that you will read from every paper. Point number 1 is majority of these nerves accompany the artery. Point number 2, that these nerves, they are mostly located at the junction of the shaft and the condyle. Now, point number 3, which has been recently been pointed out, is these nerves can be very much posteriorly as compared to the middle of the shaft and the condyle junction. So, you will find that this is the reason that when you're actually targeting these nerves, you have to follow those anatomical landmarks using your X-ray and ultrasound. I use a hybrid technique to get them in the right location, because if you don't get these nerves in the right location, you're bound to fail. So the key to interventional pain management, if you hit the target in the right spot, you should get the good result. Unless there is a element of central sensitization, then whatever you do peripherally, it's not going to work. But that's how I take this in consideration.
Great. So I think that this was also my thoughts. I thought it was a good number. I think they just put it for the heck of it, I think.
Sure.
And this was a very good number, I think.
Yeah, it is a good number. 18 is definitely a good number.
Sanjog, would you like to add something?
I just want to ask one thing, sir. So in this article, somewhere it was mentioned that they did when they did the dissection. So at many, most of the time the artery was not going along with the nerve. And
Right.
so while giving the USG diagnostic blocks, we generally use the artery as the marker.
As a landmark, yes.
So means will it give us more chances of fall?
Okay, so put it this way, there are two ways to look at this. You know, sometimes you will find the artery way high up along the shaft, but that's the feeder artery to the muscle. So don't aim at that artery. Okay. If you look at the very much initial studies, these nerves, the landmark is junction of the shaft and the condyle. Okay. And the recent papers say go distal, don't go too proximal because you're more likely to fail. And the other thing is, you know, you probably are aware the Hilton's law of the nerve supply. You want to go as distal as you can because that's where you will catch the articular branches supplying to the joint. Okay. So you don't want to target these nerves proximally. So sometimes if you don't see the artery when you're doing the ultrasound guidance, I would still go distally and I will inject at the shaft and the condyle junction, and I will only inject 2 cc's of local, and based on that I will decide if they've got a positive diagnostic block or not. So artery is a useful marker, but no, I don't always rely on the artery as a marker to do the block. Okay, if you see it, it's good. If it's way high up and if you can't see the artery in the location of the shaft and the condyle, I will still go for the shaft and the condyle junction because majority of the cadaveric studies show that the nerves are consistently at the shaft and the condyle junction.
Thank you.
Okay. Any questions, Sidharth?
I think pretty good. I think we have also put up a poll for the participants. Please help us get some feedback and also some guidance on the future topics which you would like to have. So just reply to these poll questions. We have got, so 20 of you have already replied. So the rest, please reply to these questions. They'll help us to understand the things better. I think there are no more questions, so we can just proceed with the program. And thanks for the great discussion, Dr. Sadiq, and you definitely added a great deal to our understanding of the subject. Being
no problem. Thanks a lot, Sidharth. Okay, take care. Bye bye, Sidharth. Bye bye, everyone. Bye.
And now I think we move to the next portion, which as is customary. So thank you all for attending this first journal club. So this was our first journal club, and we were planning to do this for quite some time, and finally we could pull this off. And probably we'll keep on repeating this every week, and we'll try to bring in some good papers, and probably we'll discuss them threadbare. And the biggest problem in pain community is probably we don't publish much. So please publish your data, and that will be great. And thank you, Dr. Sanjog, for the excellent presentation as well. So for the next steps, you can join our mailing list. The basic pain course is live. You can just join the course, and also I have posted the WhatsApp group link in the chat, and just join that. The secret to getting things done is definitely to act. So with these words, we'd like to just end the meeting, and I hope you have participated in the poll. Thank you for the excellent feedback. I'll now end the polling. Okay, so this was excellent. So thank you so much. Have a good night. Thank you.